Thank you. I'd like to make a couple corrections for Dr. Han. First off, this is the most complex topic. I mean, come on. And second, I was actually Dr. Vayuka's favorite resident, so that was incorrect as well. So, you know, when you look at this topic name, it just sounds kind of ridiculous, right? Candy plugs, knickerbockers. What do these things even mean? My wife, who's a physician, was looking over my shoulder while I was making this talk, and she was like, "You're just making up these words. These are not surgical procedures." But I countered that the surgical procedures in her field, which is pediatric cardiology, are even more ridiculous. So here we are. So I'm going to be talking about false lumen management, really, and it's a very visual subject. So really try to look at these figures. They're all hand-drawn, mostly taken from manuscripts, and I can definitely provide you with where those are from. So in general, during the initial management of type B aortic dissections, when we do something endovascular, or surgical for that matter, most of the time we're talking about dealing with the entry tear. That entry tear should be essentially sealed with your initial procedure if it was well planned and it was a good idea in the first place. But once you have that, all you've really done is treated the proximal pressurization. And those dissections typically extend all the way through the aorta. And in the visceral segment or at the iliacs, there are almost always fenestrations, which are essentially connections between the true and the false lumen. And even though you've sealed up top, you're going to have pressure transmitted backwards, retrograde, through those holes. So if you've seen these patients after they've had stent grafts for their type B dissections, virtually always you will see some filling of the false lumen. It hopefully will be, you know, less obvious than the true lumen after the initial stent graft placement, because hopefully there is more pressure being directed into the true lumen after your initial procedure. But this is the issue. You have this false lumen perfusion. And it's not rocket science. When you have pressure in a false lumen, eventually it's going to lead to dilation because there is less tissue there, right? There are less layers of artery containing that pressure, and eventually it will dilate. And this is really the Achilles heel of what we do to treat these type B dissections. We can direct flow into the true lumen, but we often can't prevent there from being persistent flow into the false lumen, which then leads to aneurysmal degeneration. And these aneurysms rupture. They may even rupture at lower diameters because there's less tissue containing that pressure. So when I was a young attending, I would often call my former chief resident, Dr. Han, and ask him for advice about these complex cases. And frequently his first response was, okay, I hear your plan, but what's actually happening in that artery? Like, what do you think the inside of that artery is like? And this is really important when you're dealing with these type B dissections, because they're complicated and you frequently have to tailor the fix to the patient and the anatomy. One thing is not going to work for all these patients. Whenever you have this number of procedures to fix one problem, it's probably because none of them actually work all the time. Oh, there's more. Don't worry, Dan. So you can make an argument that when you have a pressure in the false and the true lumen in a chronic case, you are dealing with an almost unfixable problem unless you do open surgery. And one of the best ways to deal with it is to just not have the problem in the first place, which is what Dr. Price was talking about with these anatomic high-risk features. If we can identify the patients that are going to go on to have dilation and persistent flow in the false lumen, and we can get them to positively remodel after the initial insult, you're going to be much better off, which is where the Cook dissection stent comes in with the scaffolding and the proximal stent graft. But honestly, even the older or just cover the proximal tear does, in many, many cases, lead to positive remodeling. And then you're not dealing with a situation where you have a chronic thick septum between the true and the false lumen with pressure on both sides, and then a really difficult situation to fix. But even so, we have options when you have that situation. So the knickerbocker. I have no idea what a knickerbocker really is, but apparently it's this type of pants. I think it's a German thing. I got this picture. I think this was Dan at Oktoberfest showing some midriff. But these are knickerbocker. They kind of flare out in the middle and then cinch down. And this is what we do frequently in our practice. And I'll describe the technique, but I think you have to remember that this is really a timing procedure. You need some mobility in the septum for this to work out. So it was described in 2014 by a German group, and it's really pretty simple in concept. You put an oversized stent graft, which theoretically can seal to the entire aortic diameter in at least one spot, and you deploy that in the true lumen, and you know it's going to be constrained by the septum and the false lumen when it's initially placed. You then find a spot where you think you can get seal, and then you balloon vigorously, and you typically rupture that septum and then cause that aortic stent graft to expand to its full diameter and seal the retrograde flow. This is an awesome picture, which Dr. Price stole, but you know, it shows you exactly what's happening here. So this is actually one of my cases from last year. And you can see that this is a kind of an AP projection, and I want you to look at the sternal wires because they're a nice reference point. And you can see in this first picture, we have a aortic stent graft, which is deployed in the true lumen to some diameter, which I can tell you is constrained by a septum and a false lumen. And then in this middle picture, you see me ballooning quite vigorously, and you can really feel when that septum yields. It'll actually give you tactile feedback. You'll see the balloon expand, and everybody will be a little puckered for a second. Usually we have a T and to make sure no disaster has happened proximal, and then we'll take some pictures of the distal afterwards. But you can see after the false lumen is obliterated and the septum ruptures, this aortic stent graft is now expanded out to the level of the sternal wires. So you can see it's flared out quite a bit in the midsection, and then distally it's still constrained. So this was a successful knickerbocker. What we do in our group is we actually use a smaller stent distally, and that is kind of a little bit of safety margin, because our concern is that the entire aortic stent graft may go out to profile and cause some issues at the distal step off. So we keep a slightly smaller graft distally, we flare in the middle, and that's how we do it. 6 months after this procedure, there's absolutely no flow in the false lumen, and it had excellent remodeling. So the concerns with this are, the biggest thing is that it's just not going to work, that you place the stent in there and you balloon, and you just cannot get that septum to move enough to really seal. So that's a problem. And then you can also have, people have described visceral ruptures after this ballooning because, things just get destabilized distally. And if this is a zone 2 or zone 3 TVAR prior, you can absolutely cause a type A retrograde dissection, even with a stent in there. So the knickerbocker has now been combined with this new technology where there is a bare metal scaffold placed in the visceral segment, which is a Cook device. And essentially the way the stabilized technique is described is exactly what I just told you about a knickerbocker, but after you do that, you then balloon fairly aggressively within the visceral segment, which sounds terrifying, but apparently you can obliterate that false lumen within the visceral segment and really kind of force positive remodeling. And the early results with this look pretty good, although there was at least one perivisceral rupture that was treated with actually I think it was more infrarenal rupture that was treated with a stent graft in the initial description. So if you can't get that septum to yield, you still want to shut down that retrograde flow. And the people have described so many techniques for this, and they all boil down to put some stuff to occlude that retrograde flow channel in the false lumen side of the septum. And the candy plug is one of the most popular ways of doing this. And essentially a candy plug is a fancy way of putting in an occlusion device into the false lumen to prevent flow. The reason we go through what I'm about to tell you in terms of making a candy plug is because there really aren't occluders that are large enough to just be placed to shut down the channel. And so the candy plug was a solution where you take a off-the-shelf thoracic stent graft, you find a way of constraining it in its midsection while still allowing the deployment device to come through the device after it's deployed so that the nose cone can still be retracted. Usually what happens is on the back table, they open the device, put a constraining suture around the midsection, reconstrain it, put it in the patient, deploy it, have enough room to get the nose cone out, and then you have this kind of stenotic stent graft in the false lumen, which you then embolize with an Amplatzer plug. People have done this in a whole bunch of different ways. Some people will telescope a stent over a smaller stent, like an iliac stent, over the thoracic piece, but there's a lot of ways to accomplish it. And people have tried everything. I mean, they've done coils. There was some weird description of like using a balloon and kind of like having it tear off and create endo trash. I mean, people have tried everything. This, I would say, sometimes works, sometimes doesn't. Sometimes pressure is still transmitted retrograde, but this is definitely an option. The endo septotomy is really, I would consider, kind of the cowboy option. Maybe some people would disagree with me, but the idea is you're trying to emulate what would occur in an open surgery where you can literally slide your Metzenbaum down the septum and really open it up and create one flow channel. The idea is that if you can get a wire or something on both sides of that septum, one on the true, one on the false, and you pull down, you might be able to cause a controlled tear through the septum and then allow you to kind of treat in a more standard fashion within a stent graft that would go, and just treat the full aortic diameter. This has been described, as I said, just with a plain wire on both sides of the septum. It's been described using laser atherectomy devices off-label to actually cut through the septum. And most recently at the Eastern Vascular, someone presented where they did a standard cheese wire septotomy where you have wire on both sides of the septum, and instead of just pulling down, they actually hooked up that wire to the source of a bovine cautery and basically cauterized through the septum, which I can tell you the idea of the cheese wire never made much sense to me because this is not cheese. This is a septum that has calcium in it and fibrin, and it wads. It doesn't really cut, and then you end up with a wad of septum just that occludes your aorta at some arbitrary point further south. So I think these cutting ideas have some merit to them, but they sound fairly terrifying, and I have not done them yet, but I would love to hear if other people in the room have that can comment on it. And that's it. That's the strange and wild world of false lumen management.